PMJ, in a country as geographically vast and culturally diverse as India, needs a strong foundation with an innovative approach. The states and union territories have time and again used different innovations to improvise the scheme and make it a better fit for their distinct geographies and regional context. Today's session on states' best practices and innovations is one such opportunity for the states and union territories to showcase their successful initiatives. Without further ado, it is my honor to welcome our distinguished panel today, led by Chairperson Shri Mohammad Suleiman, a member of the Indian Administrative Services, batch of 1985. He has more than 30 years of experience in leadership roles across government sectors and departments. He currently serves as Additional Chief Secretary, Department of Health in Government of Madhya Pradesh. We welcome you, sir. Okay. I would also like to invite upon stage Dr. Pradeep Vyas, ACS, Maharashtra, to join us on stage to co-chair the session. Our next panelist for today is Shri T.K. Anil Kumar, a member of the Indian Administrative Services, batch of 1995. He has rich experience in leading the state of Karnataka in important portfolios such as urban development, DPAR, tourism, and medical education. He currently serves as Principal Secretary, Department of Health and Family Welfare, Government of Karnataka. We welcome you, sir. I would now like to welcome Dr. Ratan Kelkar, a member of the Indian Administrative Services, batch of 2003. He has served in various capacities across government departments in the state of Kerala. At present, he is holding charge of Secretary, Electronics and Information Technology Department, Government of Kerala. In addition to the charge, he is also holding additional charge as State Mission Director, National Health Mission Kerala, and Executive Director, State Health Agency Kerala. We welcome you, sir. Our next panelist for today's session is Shri Prasanna R., a member of the Indian Administrative Services, batch of 2004. He has worked extensively in the Government of Chhattisgarh and currently serves as Secretary Health, Government of Chhattisgarh. We welcome you, sir. I would like to now invite our next panelist, Shri Bhupinder Kumar, a member of the Indian Administrative Services, batch of 2011. He is a young and dynamic officer who has served across various administrative positions in Jammu Kashmir and currently serves as Administrative Secretary, Health and Medical Education in Jammu Kashmir. We welcome you, sir. Last but not the least, I would like to welcome Dr. Amit Paliwal, who brings with him more than 2 decades of progressive and wide-ranging experience in various aspects of health systems, strengthening social health insurance, health communications, IEC, SBCC, and human resources for health. He currently serves as Project Director, GIZ, Indo-German Program for Universal Health Coverage. We welcome you, sir. While for today's session, we have 5 states presenting their best practices. This year, we have received more than 30 best practices across the country in different thematic areas of the PMJ scheme. I would like to call upon stage our moderator, Dr. Rohit Jha, to come upon stage, as well as I would like to invite. So we're going to have the book launch today for the state's best practices and innovation booklet, which has been compiled across all the different states with their best practices. And for that, I would like to call upon stage Dr. Ruchira Agarwal, Principal Consultant, Head of Monitoring, Evaluation and Research, who has been instrumental in compiling this booklet. I would like to also call upon stage Dr. R.S. Sharma, CEO, National Health Authority, to come for the book launch for the state's Best Practices and Innovations booklet. And I would also like to invite Dr. R.K. Patel for this. We would also like to invite Dr. Ajay Sharma, Secretary Health Punjab, to come upon for the book launch. And we would also request CEO Telangana to please come up on stage to help us launch the book. I would also request the clicker to be presented to our chairperson.
Ayushman Bharat Pradhan Mantri Jan Arogya Yojana is adopted and implemented by 33 states or union territories which are continuously working on new processes and innovations to overcome various implementation challenges. Presenting PMJ, Best Practices and Innovations Book that complies successful initiatives undertaken by PMJ implementing states that will inspire and motivate all to continuously strive to improve scheme efficiency and effectiveness. Over 40 best practices shared by 24 states and union territories across India have been featured in the book. Be it beneficiary feedback referral mechanism in Jammu and Kashmir, or some remarkable IEC campaigns in Kerala, or the Vande Gujarat Vikas Yatra to increase beneficiary enrollment in Gujarat, to branding of health facilities in Meghalaya, we have compiled a wide range of best practices adopted by states. All this and much more. Download your copy on pmj.gov.in.
Thank you, everyone. I would now request our moderator, Mr. Rohit Jha, to open the session for discussions.
Hello. So good morning, everyone on the dais, and good morning, everyone present in this hall. Today's session is very special because this is a session dedicated for the states. Like we would like to, we have the tradition of having a state showcasing what they have done over the years and selecting few of them to present before everyone in the you know, like we have 33 states, so 4 or 5 of the best practice we select for those who have actually been who have actually made transformational impact on the implementation of the scheme. So that those are their best practices. That doesn't mean that other states have not really implemented good practices. We have as just before the launch, sometime before we have launched the booklet, the best practice booklet, which contained best practices from almost all the states. So we have verticals like, so if we talk about the stakeholders, we have beneficiaries, we have hospitals, we have SHA and NHA. And if we talk about, these are our key stakeholders. And if we talk about the processes, then starting from beneficiary awareness, then we have hospital admission, pre-authorization, claim settlement, and subsequent to that, we also have grievance redressal, fraud and anti-fraud initiatives and all. So these are some of the key areas where we look forward to the practices which actually strengthen the implementation of the scheme. So today we have a set of August panelists with us. These are the states, not like, I repeat that all the states are doing great work, but these are the states who have really done great work in respective areas for which we have chosen them to present their case studies, to present what new initiatives these states have brought. Today we have Mohammad Suleiman sir, who is the ACS Health Madhya Pradesh, and he is chairing the session. We have co-chair Rajpradeep Bas sir. He is ACS Maharashtra. We have TK Anil Kumar sir. Sir is Principal Secretary Karnataka. We have Prasanna Kumar sir. He is Secretary Health Chhattisgarh. We have Ratan Kelkar sir. He is Secretary IT and the CEO or Project Director PMJ CASP Kerala. We have Bhupinder Kumar sir. He is Secretary Health Jammu and Kashmir. And we have Dr. Amit Paliwal sir, who is the Project Manager GIZ India. So I would quickly like to now invite the states for the presentation. And the format of the session would be that we will have presentations. Thereafter, we would like to have a rich discussion on those topics on the select areas. And I would request all the panelists to, I would humbly request that please focus on the thematic areas for which the state has been requested for making the presentation. The stats have already been presented across many sessions. So we would primarily focus on what are the thematic areas for which states have brought initiatives or innovations. I request I would request TK Anil Kumar sir, Karnataka, Secretary, Principal Secretary Karnataka, to make presentation on the topic or the thematic area which we have decided for Karnataka is the integration with larger ecosystem, the PMJY integration of PMJY in the larger healthcare ecosystem, and the online referral module which the state is implementing. So,
Esteemed panelists, ladies and gentlemen, very good morning to you all. At the outset, I would like to thank the NHA for inviting us to this two-day Manthan session. It's a very informative and it's a good platform for sharing a lot of information, and we will be learning a lot of things from different states. I would personally thank Rohit and CEO sir for taking this initiative for sharing ideas across states. I have a very small presentation on the PMJY as it is being implemented in the state of Karnataka. Essentially, I have just three things that I want to kind of put across. So we have a very unique referral module that does not exist in many of the states. Yesterday we did see the presentations from Uttaranchal, from Meghalaya, and across sessions also some presentations were made. So this referral module is something that has evolved in Karnataka, so that's something that I'm going to stress upon. And second is how we are aligning the PMJY scheme with the health infrastructure or the health department itself. And the last third point is how do you motivate the doctors, especially on the public health institutions, to take up the PMJY activities. So these are the 3 points that I would like to stress upon. Yeah. So this is how the PMJY program took off in the state of Karnataka. So prior to the PMJY launch, we had something called the Arogya Karnataka Assurance Scheme, which was launched in the March of 2019. Now you must realize that this program was essentially trying to put together 4 or 5 different programs that were in operation in the state. So we had the Yashaswini scheme, which was there for more than a decade. There was the Rajiv Arogya Bhagya. There was the Mukhyamantri Santwana Harisha Yojana and Vajpayee Arogya scheme. And we had the RSBY. These were different schemes catering to different aspects of healthcare. And these were all now put together in Arogya Karnataka initially, and subsequently when the PMJY was launched in October 2018 with a 5 lakh cover, this got merged and was converted into the Ayushman Bharat Arogya Karnataka scheme in Karnataka. Now this is where we stand. We have 31 districts. We have around 3,506 hospitals which are empaneled. You will note that the public empanelment is very high, 2,934 hospitals are there, and the private hospitals at 572. It's a universal scheme. We have 5.09 crore people. So the back-end data is the NFSA data. So we take the food data, and 1.15 crore, that is 115 lakh BPL families are covered. 19 lakh APL families are covered. We have joined with the NHA for doing the co-branding of cards. In the last month, we have generated nearly 45 lakh cards, and that's something that we want to achieve by the end of this year. By December, we want to cover the entire population. We had issued cards in the earlier regime of 1.78 crores in the when it was done locally. The number of beneficiaries treated is around 36.71 lakhs, and 4,994 crores is the outflow that has happened. As you are aware, PMJY, the coverage is 5 crores. It excludes persons with other forms of insurance. We also cover the APL with 30% package up to 1.5 lakh coverage. We have still not adopted the HBP 2022. We have 1650 procedures currently, and they are categorized as this 2A, 2B, 3A, 3B. So simple secondary, complex secondary, tertiary and emergency care is provided. you must note that we don't need a card. I mean, it's the Aadhaar card or the ration card which the beneficiary uses to make use of the PMJY benefits. Now, the SHA that we have is the Swarna Arogya Suraksha Trust. It's on a trust mode. The board chairman is the chief secretary. The executive committee is headed by the Principal Secretary, Health and Family Welfare, and decisions primarily are taken at the executive committee level. That is the basic structure of the SHA in the state. This is the coverage that we are looking at. As I mentioned, the targeted beneficiary, APL is around 17% and 83% is a BPL beneficiary. And if you will note that the BPL beneficiary, 90% of the people who are treated are in the BPL category. Now, this is the first thing that I wanted to put across. Of course, there will be a lot of questions on this as to whether this is the right mode to do or not. You must understand that this model was adopted based on the learnings from the earlier schemes. I had mentioned some 5 different schemes which were kind of all the learnings were taken into this and converted into this new scheme. So essentially what we are saying is that there is a referral under the Ayushman Bharat Arogya Karnataka, where persons have to go to the public health institutions. It's like the CGHS model, where you go to the public health institutions and certain procedures have to be done in the public health institutions itself. So there is a simple secondary healthcare, 294 procedures only have to be performed at the government hospital. These include around 40 of those simple secondary procedures. There are complex secondary health procedures which are 251 in nature, and tertiary care which are 934 procedures. There a referral is required from the government hospital. So this is again a gatekeeping exercise that is done at the PHI level, which may or may not be there in several states. Of course, there are 171 emergency healthcare procedures which a person can go directly to the empaneled hospital because of the nature of the health reference that is required. So of the total of 1650 procedures. Now, so first question is this ring fencing. So certain procedures, what we call simple secondary general procedures, which can be done by the MBBS doctors, are to be done in the public health institutions. So this was learning from the Yashaswini scheme, where we found that many of the procedures were being done in not so well set up private institutions, and Karnataka government has put in a lot of money in the public health institution. You must realize that each state has to find its own feet. We have 21 medical colleges across the 31 districts. We have in total 63 medical colleges across the state. There are around 10 super specialty hospitals that have been developed, institutions like Kidwai. So there is a certain amount of strength in the public health institution from the supply side part of it. So that is why this mechanism has been put in place. Now the online referral module. So one of the major issues for this referral module is that collecting the data as to who has referred, how much time did it take. So the online referral module has also now been launched. So there is a data point that is generated as to how many referrals have been made from a particular hospital, which doctor has referred, how much is the time taken for doing the referral. So these has been launched recently in the last 3 months, and that will be helpful in streamlining the whole referral module. So this gives you an overview of how it happens. So there's a specialist in the hospital who kind of comes to a conclusion that this particular procedure cannot take place in the government institution. And a supervisor, that is a Swarna Arogya medical coordinator, who signs off that yes, the referral is required and a referral is made. The person is given a referral document which lists out that this particular procedure has to be done in the private institution. And attached is a list of all the private institutions. So he is given a list from the hospital with distance as to which are the institutions which have this particular facility, and he can choose to go to that particular institution and do the procedure. So this was the first thing, this concept of gatekeeping and ring fencing some procedures with the public health institution. So this is something that is unique. Of course, it's debatable. I mean, we have to improve the system. I'm not saying that it's running at in total efficiency, but it's a system that has given us some good results. Second concept is of integrating this state health authority with the larger health ecosystem. What I intend to say is that once we have a scheme like PMJAY, we need to align it with the concerned department. So at the state level too, we have the SHA, which is headed by the executive director. Then we have the commissioner's office. The commissioner office also has something called an ABRK cell with consultants. They munch on the data as to how many referrals are being made, how are the PHIs doing. So there is a lot of review that happens, and there's a lot of pushing of these public health institutions to take the benefit from the PMJAY scheme. Similarly, at the district level too, there are steps that have been taken. First, of course, universal empanelment of all the public health institutions. That has happened. We have roped in the Deputy Commissioner as a appellate authority in case of disputes. There's a district leprosy officer who's a nodal officer for ABRK. Then there are instructions issued under the Karnataka Private Medical Establishment Act, which we tell them to make use of the PMJAY scheme. So there is an alignment that we have tried to do of the scheme and the department. Another aspect, of course, is capacity. If the scheme has to be used, you need to kind of ensure that the institutions have the capacity. So I'm looking more at it from the public health institutions. So you have a claim executive that has been provided in the public health institution. There are freelance DEOs who do the data entry work. There is the Savarna Arogya medical coordinator who oversees this referral modules. And of course, there are the Arogya Mitras who help the beneficiaries when they come to the hospital. So these are points where we try to enhance the capacity of the institutions to latch on to the PMJAY scheme. This is the third point that I wanted to stress on. So there is a flowback. Yesterday, Mr. Manoj Jalani spoke about how money goes back to those institutions where these procedures are being attended to. So in a regular scheme of things, probably money would not have gone back to the institution. So there is a flowing back of the money from the PMJAY to these public health institutions. So for simple secondary care, we gave 50% of the money. So there is a format for that as to how the money goes back. But the interesting aspect is this incentive, that 15 to 30% incentive is given. So if the further away you are from the district hospital, the higher the incentive you get to do those procedures. So there's an incentive mechanism put in place which enthuses the doctors and the staff to take up the PMJAY procedures. So this is how it looks like. The number of beneficiaries treated over the years, if you see, there is a steady increase, and we have nearly touched around 7.87 lakhs in the current year. You will note that although the private beneficiaries who are treated is around 16%, the outflow is around 2,920 odd crores. This is primarily because the cost of tertiary care is much higher. So the outflow to the private sector where tertiary care is not available, the amount of money outflow is very on the higher side. Now this is as far as the simple secondary procedures where there's been a steady increase, and this has been primarily because of the alignment where the commissioners have been reviewing it, pushing these public health institutions. So you must realize that 21 medical colleges exist in these district headquarters, and these medical colleges have the capacity to take up complex secondary and even tertiary cases. This is just to give you an overview of the milestones, that how public health institutions have kind of latched on to the scheme, and the number of procedures that they have taken up has increased over the years. Just to give you an overview of the entire scheme. This is my last slide. Of course, going forward, we need to look at the turnaround times, both for referral, for claim settlement. So essentially, we try to settle claims for the private hospitals on a priority basis, the public health institutions. So since the Savarna Arogya Suraksha Trust is a completely government-operated organization, it has to become nimble, because you need to address the problems at hand, and the TAT, if it has to be improved, they need to get more people on board, take quick decisions. So that is something that we are looking at. We have to be strengthening the specialty services. There is a corpus money that is generated, which we flow back to certain institutions which have the capacity. So if they don't have equipments, we will be providing equipments to those institutions. So increasing the claim processing by doctors and claim executives, integration with the NHA TMS, strengthening the accounting and audit trail. We have a system which is fairly robust, but to ensure that more and more private institutions come on board, we need to, one, adopt the HBP 2022, at the same time strengthen our audit, accounting and audit trail. And quality of care has to be improved. So these are the three vital points I wanted to share with you. Essentially the ring fencing and the gatekeeping that we have, aligning the department with the scheme, and last, have a system to motivate the doctors and the staff to latch on to the PMJY scheme. Thank you. Thank you, one and all.
Thank you, sir. First of all, I would like to acknowledge the support of sir. Sir has been very instrumental in a stronger coupling of the Arogya Karnataka scheme with the PMJY, which has actually gained some momentum over last few months. And regarding the topic of the presentation, ultimate goal of the PMJY is that the public hospitals would flourish. Public hospitals would come into a stage where they can provide, where they should be self-sufficient and can compete in the free market and attract beneficiaries in a sustainable manner. So, of course, there is a debate that what is the right way? Is it about the choice? It is about the sustainability. And Karnataka has provided a way forward, that is the online referral. There is pros and there are pros and cons, which we'll discuss in the later part of the session. And one more thing I would like to highlight about Karnataka, which of course was not the part of the discussion today, that Karnataka is implementing a different kind of universal health coverage, that is co-payment model, not the co-contribution model. This adverse selection is always a challenge. Like yesterday also we were discussing about the USC. The co-payment model is that instead of paying the contribution, sharing the contribution upfront, the beneficiaries would pay a part of the hospital cost. So they are 33% of every time you go to the treatment, for availing the treatment, the beneficiary has to pay a 33% of the charges. So that way they are able to, somehow control this adverse selection. That's really a good model. And those states who are really willing to go for USC may kindly look into this. Sometime we can ask Karnataka to make a white paper on that, and they may probably share with all of us. Now, I would request Mohammad Suleiman sir, ACS Madhya Pradesh, for his presentation on. He is the chair of the session, and sir, I would request you to kindly make presentation on Beneficiary Facilitation Agency and Anti-Fraud. Beneficiary Facilitation Agency is a new concept. Of course, we have borrowed it from Punjab, and this was like with full force. Our CEO sir has said that this has to be implemented, and now Madhya Pradesh has been one state which has really done a great job, and we will see that it has brought lots of improvement in the uptake in the public hospital. Also, in last few months, Madhya Pradesh have taken lots of initiative in anti-fraud initiatives. I request you, sir, to kindly present, sir. Thank you, sir.
So I will be conscious of the time, so my presentation may have many more slides, but I'll try to be as brief as I can be. Let me start by thanking NHA for having this two-day conference, and especially for inviting states for experience sharing. There's so much to learn from what others are doing, and everybody need not invent everything afresh. So one of the challenges that we face in implementation of this program in last 4 years is how to make government institutions more receptive to this, and how should we increase the participation of the public institutions. So model that we thought might work better is to create a beneficiary facilitation agency. Kind of a misnomer, because it's not really facilitating beneficiary, it's actually facilitating hospitals, but still we call it beneficiary facilitation agency, because in some way it also addresses the concern of the beneficiary, that means the patient who is walking up to these public hospitals. But in reality, the implementation resulted into better uptake of scheme in public hospitals. So what was, we analyzed the reason for low uptake of the scheme in the public hospital. There are behavioral issues coming from the staff of these government institutions, resources. Most of our public hospitals will not have trained IT manpower to do the data entry kind of a thing. Then, unfortunately, the reality is this, that many government hospitals will not have specialist doctors. The MBBS doctors would be there, but there will be large number of vacancies for specialist doctors. There are some administrative reasons, especially at the level of CMHOs, where there is very little ownership of the scheme, and there's some problems also. I keep saying this, that if the opportunity is there to a private person, he would much rather walk to a private hospital rather than to a government hospital. In the same way as we want to send our children to private schools compared to the best of the government facilities. So there is some problem, and it's a perception issue. Many beneficiaries would say that the government system may not be so responsive, there might be delays, services may not be of quality. So these were some of the reasons that we analyzed internally that is hampering the uptake of the scheme in the public hospitals. So we thought that we need to do something so that all these issues are addressed and the scheme uptake in the public hospital improves. It's important for us because there's a lot of money involved, and if part of these funds flows back to these public institutions, it actually strengthens the infrastructure in those institutions. Institutions itself become stronger because of this scheme, and that was one of the goals that we decided. In addition to that, we need to provide better care. The doctors have to become much more sensitive towards the need of the patients. So in one slide, this is some of the achievements of it. We introduced this scheme in December 2021. We're not even 1 year now into this scheme. Look at this, active hospitals. The public hospitals, only 154 were active. Active means they were actually taking patients. Now we have 320 of them on board, all of them are active. That means everybody is taking some patients, so coverage of the scheme has improved tremendously. Claims per day, before the agency was in place, we had 784 claims per day in public hospital, went up to 1574, again almost 100% increase in number of patients walking up to the public hospitals. This ratio is an important factor, especially for the government to monitor what is the ratio of the public and private in terms of treatments under this scheme. Used to be 40-60 earlier, changed to some extent 45-55. Still there is work to do in this. So these is just the same number in a little more details. One of the important factors is turnaround time. It has also improved within TAT now. Earlier we used to have only 84% within TAT, now it's 93%. Even the claim submission in the public hospital, there used to be the weakest link. Even if the patient were there, they'll not submit claim and get this money. Within TAT it was only 47%, has gone up to 69%. There were claims pending earlier before this BFA were done. There were more than 30,000 claims which were pending. They got cleared, and they were pending because of process issues before documents not being complete. With the BFA coming into it, this is also now completely done. Pre-authorization claim rejection has gone substantially down, almost down by 100%. Tertiary care package, which were earlier kind of non-existent in public facilities, they have also improved substantially because of the BFAs being there, and they are being continuously on the job monitoring and everything. And look at these numbers, looks small when you look at the overall picture, but we could distribute 14.55 crore to the public hospitals, which went on to improve their infrastructure. In one district hospital in Jhabwa, which is one of the most remote tribal areas in our state, we could distribute 80 lakh rupees to a single hospital for infrastructure improvement. One particular doctor in that hospital got a claim of 10 lakh rupees, one person getting a claim of 10 lakh rupees. This is a kind of a cost-benefit analysis. 385 plus GST is what we pay to this beneficiary facilitation agency as a service fee for each claim that comes to it. And in 2 quarters, we paid around 2.89 crore. The benefits I already discussed, that over the numbers we have achieved using this thing. So I would say it's a very cost-efficient way of increasing the participation of the public hospital. And in fact, we are now experimenting in putting a BFA in the private hospitals as well. Let's see how does it roll out. Now, the second part of my presentation is not so good. It's not really happy, because here I talk about what kind of fraud we see in implementation of this scheme. I would say, medicine is a very noble profession, but there are guys who, because of their own self-interest, won't think twice about discrediting the institution as a whole. And we have to keep an eye, especially in this phase when we are in the expansion mode. I hope all of you would understand this fact that PMJ is the largest scheme ever implemented by the government, especially the state government. I have now almost 3 crore cards distributed to beneficiaries. I don't even have land records to that kind of a number. It's a huge numbers. And then many of them coming to the hospital. So the scope and the potential of the scheme is actually huge, and we have to be alert to it, because we still don't have administrative skills and managerial skills to ensure that everything goes on smoothly. So we need to be continuously alert to this. So what we have done in terms of trying to ensure that a scheme goes as it should be. The first is a call center concept that we introduced in Madhya Pradesh. 2 kinds of it, inbound and outbound. Inbound is, when you have hundreds of hospitals in districts who can provide service, and all of them don't provide same service. I heard this beautiful word which kept on repeating, many of the speakers were talking about, is citizen-centric. Now for an Ayushman beneficiary, it's a different kind of a citizen. He doesn't have access to information. We can say that such and such hospital is impaneled under Ayushman. The reality is that such and such hospital is only impaneled for 1 or 2 specialty of Ayushman. There is no hospital which provide every service under the Ayushman package, more than 1600 packages. So how do you inform him that which is the nearest hospital which you can go and you can have access and get yourself treated? So this inbound call center basically provides that function. He can call up and check if he is having a particular problem, which hospital he can approach and how it would react to him. And there is an outbound call center, which basically takes care of the fraud part. Every day, out of the patients admitted, the outbound call center calls them up and check them whether they are actually in the hospital or this is just their name which is in the hospital, and also to check whether they are being treated or they are not being treated. It's kind of a concurrent process. So these are the 2 call centers that we use. We do a concurrent audit of beneficiary cards, whether the card is genuine, pre-authorization is correct, claims and beneficiary audit. We also do the desk audit, which is basically a post-activity. So all these channels we have introduced, there are many of them. I only wish and hope that in the future we don't need to use them, but we have desk audit, we have field audit, we have beneficiary home visits, we have beneficiary hospital visits, then ISA audit, then NHI triggers, all kinds of things. And with very limited manpower, we need to do this to ensure that the thing is that it should be. Every audit has some of the tasks assigned to it. Desk audit is supposed to check whether it's cloning, whether repeat billing, over treatment. I realize that many hospitals, they are so liberal in their approach that they want to put every patient to ICU only. There is no concept of getting a normal hospital bed, and they simply discharge from ICU back. They're just liberal, so to say. So whether they are doing over treatment and wrongful card generation, we have seen cases of phantom billing, conversion from OPD to IPD. We have certain packages, as Karnataka was talking about, gate peaking, which are reserved for government. Then some of the hospitals want to misquote them and use those packages also, out-of-pocket expenditure. So all kinds of things that we keep noticing, and we have to keep taking actions on those. What we have done so far, 99% of our card are Aadhaar verified. To my horror, a few days back, I realized somebody sitting in UP could create 120 cards in Madhya Pradesh. using all kinds of fraudulent methods, and then one had to simply do something about it. So now all our cards, 99% of them are Aadhaar verified. We no more issue cards unless we are completely Aadhaar verified. Rest of the card also in the process of being Aadhaar verified. Then at the time of pre-authorization, we do again a concurrent audit of them, whether the card is valid or not. We have so far disabled almost 3.5 lakh cards, which we found were not correct when they came there. So this 100% Aadhaar verification of the card is the key thing to ensure that only eligible beneficiary is taking the treatment of these facilities. Then we are doing concurrent desk audit of 10% of pre-authorizations. Then we are doing 5% audit of the claims that have been submitted by the hospitals. We have monthly review meetings with the hospitals. We have hired retired government doctors to do to audit the claims whenever they are required. And we also do a kind of a physical beneficiary audit. In fact, one day I had to put teams to audit 57 hospitals in a single day, just for checking that the pre-auth they are saying are actually there or not. So this surprise visits I found to be the most effective tool in in ensuring that the hospitals are doing the right thing. We while we do audit, though we talk of all kinds of empanelment criteria, but still we verify hospital infrastructure, availability of human resource, and what kind of treatment is being provided, whether it complies with the guidelines or not. So what we have done so far, we have de-empaneled 19 hospitals because of these fraudulent practices that we noticed. Out of around 400 private hospitals, 19 looks like a big number. It shouldn't have been that high, but we had to do that. We suspended wrongful claims. We recovered from them around 5.5 crore, which they had already charged, and we had to recover and adjust. There were some out-of-pocket expenditure in 108 cases, almost 3 crore, which they had charged in addition to the Ayushman thing they had charged, and we had to recover that. In some cases, money was also refunded to the beneficiary. Almost 1 crore rupees were actually refunded to the beneficiary from whom they had recovered. So, this is an exercise which continuously, we have to do. The way forward that I see is that we need to hire an agency. The governments are always short of people. We don't have doctors. So we need to hire one more agency to do desk and field audits. We insist on 100% Aadhaar verification for the cards. Out of the 1600 packages, the most misuse that I saw was in something called medicine-related packages. And we need to really maybe follow the Karnataka model in ensuring that private hospitals have very limited access to the medicine package, especially the ICU package. Some of the package, the rates are very high. I believe the COVID test is still around 2,500 rupees, though in market now we can get it done in 100 rupees. So that kind of a thing we need to ensure that those things are also taken care of. Thank you.
Thank you, sir. I again would like to acknowledge support in this law, in the implementation of the scheme over last 2 years, almost 1.5 years. The Madhya Pradesh has changed the gear, and it's now swiftly entered into the set of states who are really implementing a scheme in a great way. And this is manifested through the number of claims which we are getting from Madhya Pradesh, almost 5,000 claims per week nowadays, starting from almost 1,000 somewhere in 2019 sort of 2020. So thank you very much, sir, and also the CEO SHA, sir, is also sitting here. We acknowledge your support for that, sir. With respect to today's presentation, the fact that we have 320 active public hospitals is talking a lot about how BFA has been really successful. So that is, few states are skeptical about the utility of the BFA. This is really a testimony to the fact that the BFA concept is really doing great. And another thing that states have really said many times, that they may start converting OPD into IPD. But what I see here, as sir has presented, that from 21,471 tertiary claims, the number of tertiary claims has become twice. It is 42,974. So it's not just that they are doing some small cases, but they are also converting the secondary into tertiary. no, sorry, not secondary road, they are also converting, or maybe like they are increasing the uptake of tertiary care services in the hospital. The last thing, as sir has said, that okay, no matter how much effort we put to get out of this fraud and abuse, this is not really, you know, like this is collateral menace which we, as we grow bigger and bigger, this will also grow big and big with us. But yes, we need to really put some kind of efforts to see that this is not really becoming out of control. And sir has said that surprise visit is very important. And yesterday we heard from the CEO Maharashtra, Sudhakar Sindhe sir, that out of 1,000 hospitals impaneled, he has visited 750 hospitals. So that's again a takeaway from this presentation, that the senior leadership, if they visit the hospital, that is definitely going to make, you know, sensitize hospital against any anti-fraud abuse activities. So now I request Ratan Kelkar sir, Secretary IT and CEO State Health Agency Kerala, for his presentation on IEC initiatives in the state. So before sir makes presentation, I would like to say one thing, that Kerala is one state who could get almost 100% families with at least one Ayushman card within 6 months of a scheme implementation. So that is one thing which is really, you know, appreciated, and rest all of the states are now doing this. So we can really, that deserves accolades for Kerala. Also the fact that even today, Kerala, without any push and pull mechanism in the state, is 68% of the claims are coming from public sector, public hospitals. So that is again a great initiative, and of course, like leadership along with the public healthcare infrastructure deserves appreciation for that. Now I request sir to make the presentation. Thank you, sir.
Thank you, Rohit, for your kind words of encouragement. I realize that the slides are being handled by somebody else. I'm not sure, because by the time I came, everything was put online. Am I handling the slides or somebody? Yeah? Okay. Because that gives a lot of comfort, because when we are talking about empowering people, at least I need to be empowered to move the slides. So thank you, Rohit, for that gesture. So just to give a snapshot of what we are trying to do, or rather I would limit myself to the topic of what I'm supposed to be speaking today, that is, how do we empower citizen. To even go to that empowering of citizen, I think what we first need to do is to empower our own staff to take decisions and take the appropriate decisions which they do. And in my case, I'm extremely happy that I have a very motivated team in the State Health Agency, which does a lot of activities of empowering the citizens. So what you're seeing here today is because of the empowered staff of State Health Agency, which has delivered the desired results. So the SHA of Kerala is quite new. We are just 2 years old, and we celebrated our birthday, the second birthday, last July. And we've done extremely well from the day of inception, especially now that we are speaking about empowering people. The motto that we follow is, the department will not be able to do each and everything for you. Every person's health is his or her responsibility. So our motto of the department is, your health, your responsibility, because when you're talking about health in a community, you can't put the entire burden on a department or a few departments to deliver. It's the community which has to come forward and own up maintaining health of that particular community, and to that extent, the department can just be a facilitator. It will not be able to do each and everything that you expect. So we have put the onus on the people, and luckily Kerala, being a very informed society, they have taken it up as a challenge to empower themselves, and that is why I am standing here before you for this particular session. Here I would just like to pinpoint that we've been able to give an Ayushman card to every family that is an eligible family in this scheme. So all the 42.04 lakh families who are enrolled into the scheme, that family has been given one card. So now the entire drive of giving cards to others is being undertaken, which I would like to do, but every person who is coming with a family card will be given a card at the hospital setup. That kind of an arrangement we have done. And one of the heartiest things to inform all of you is the highest utilization of the claims in this country comes from the Government Medical College of Kozhikode and Kottayam. And I will tell you why people go to a government facility in Kerala vis-a-vis the private facility. So now coming to the IEC strategies, I mean we all do the routine IEC business of informing people, but how do we convert that information into empowering a person in terms of changing the behavior of that person to the good? I think that is where we are looking at working on. Though in Kerala people are accessing various media, the information about the scheme is with them. But unless we establish a one-to-one contact with that person and change the behavior, one towards the preventive and health and wellness aspect, and second, if that person is sick, how do you access a facility? What are the do's and don'ts? That will come if you have a one-to-one kind of a mechanism with the public, with each and every citizen. That is what we are looking at doing now in Kerala. So these are some of the routine things which we all do, but two important components here we do a little bit differently is engaging with community-based organizations who then engage with every citizen in that community. That is one thing which we do effectively. And second, convergence with various line departments, because a lot of departments have multiple schemes for the same clientele. I think we are kind of looking at and also being quite successful in ensuring convergence of activities towards delivering the common public good. Now, what are the objectives of IEC? I think it is more of empowering the beneficiary and the stakeholders, which will make the ecosystem better to function. I think that is what is the impact of an IEC, but to an extent, until the behavior changes, the IEC will have no meaning just by putting some advertisements and fancy things in various media and we being happy about it. Unless the person doesn't really relate to what we are going to tell or what we are saying, then the entire, the fun of doing IEC is lost. So one of the things which we started off with when we started the SHA in July 2020 was to have a common recall value for what we are doing amongst the people by having common branding of all our activities, including IEC. So we have a common hospital kiosk. This is a kiosk which is there in all the empaneled hospitals, both public and private. We have three different modes of implementation of this kiosk. What I'm showing here is a high-end mode which is in the medical colleges and hospitals. At the district and sub-district hospitals, we have other modes of hospital kiosks, or rather models of hospital kiosks. But the color combination, the messaging, everything remains the same, so that whether it is IEC in social media, on the physical platform or elsewhere, the color combination, the messaging, everything remains the same, though there is a kind of a recall value for what we've been doing. We have a newsletter which we send to everybody, and including all the departments, all the hospitals and all the people, so that they are aware. All the people's representatives, we give it to them so that they are aware of the scheme. We do an awareness through the public distribution system, since all the BPL go there for ration. That provides a venue for us to reach out. We have converted all our hospitals into the walls of the hospitals into branding. We brand all the walls, so there is a bit of a impact which this creates on not only maintaining the premises neat and clean, but the important message also is given to people. And this is through the OP ticket. This is a very important activity which we did a few months back. Though the Kerala society is highly informed, we realized that unless we do a one-to-one touch point with the citizens, we will be failing in telling them the benefits of the scheme, or rather how do we prevent the fraud. So to that extent, we had a very strategic workshop. We also had representatives from the NHA, which was also a very good for us to take this discussion forward. We have had discussions with the Labour Department, because we have a community of over 25 lakh migrant labourers who visit Kerala and work in Kerala. We have had tie-up with Education Department, because we believe once a message is sent to a child, I think the parents and the next and other relatives and etc. would also get to know about the scheme, because once we target a child, the child would be our brand ambassador. And reaching out to SC and ST women, and also through the, not only the women, SC and ST population, through the various mechanisms of the department, through their officers, we've been able to do that, women and child. Another niche activity which we are doing is with the Speech and Hearing Institute. We would want them also to get the benefit of what we're doing. Though they know about the scheme, if they want to really be a part of it, we also need to create a braille system for them to understand even the card. So we are converting all the cards for differently abled, especially the visually blind in braille. And UNICEF has been supporting us in a big way in taking the initiative forward. Now, this is some snapshot of the activities we do with migrant laborers, and migrant laborers are also, and even the targeted intervention groups of the NACO. We work very closely with them so that we can pass the message to them. What we need to do is, we may have our own mechanisms of informing people about the scheme, but there are already foot soldiers of various activities which we can tie up easily, and they would probably be having better communication channels opened up with those targeted groups. So I think this would help us in breaking the ice and passing on the message more efficiently. So in Kerala, we are very lucky to have a very robust community-based engagement with Kutumbashri. We have other civil-based organizations who reach out to the target group more efficiently than, and also the Ashas who reach out to the target group more efficiently than otherwise. So we work very closely with them. And campaigning through schools is what we do. And wherever there is a gathering which happens, we ensure we also tell about our scheme. Newspaper advertisements, the routine things. This is a postal cover and my stamp activities which we do very efficiently. This idea I borrowed from Mr. Suresh Shastri from Karnataka, who is also there in this room. So to that extent, sharing of experiences in such kind of gathering also gives us ideas about what we can do differently. And this is a activity which we do with all the EHCPs. Our district program coordinators have a mechanism of connecting with all the hospitals every month so that their grievances are redressed to an extent in terms of the scheme, and also the various fraudulent activities which are noticed at the districts can also be settled at that level. Now, the impact of IEC has been to an extent in the last 2 years, we have been able to empanel more private hospitals, and we are very strategic in doing the purchase of services from the private sector, and we are very strategically using, and also the private sector, and also geographically monitoring what are the kind of private sector specialities which are needed for the scheme and wherever there are gaps. So one important thing which we've also started doing as part of empowering the beneficiaries also to ensure that there is convergence of various other state schemes which we are finding in the state of Kerala. We've already successfully integrated one from the lotteries department, and we are looking at integrating other health schemes of other departments, including NHM. And what I've also noticed is at the Government of India level, I think the kind of the golden handshake between NHA and NHM has not happened to the desired extent. For example, RBSK can easily be subsumed under this easily. The scheme of ophthalmology which exists in NHM can also be subsumed. Deafness, like that, the various national programs which are running in NHM, which can easily be tagged with the PMJ scheme. I think that kind of a convergence should happen at the national level between NHM and NHA. I'm told it is happening. We would look forward for a speedy handshake at that level. So this is all I had to tell all of you, and ultimately the empowerment of the citizens will not come by we beating our drums at various levels. It should come by empowering them in the strictest sense, by they believing that they are also responsible for their own health and not any particular department. So I think to that extent Kerala has been quite successful in empowering the citizens. Thank you.
Thank you very much, Ratan Kelkar, sir. I again acknowledge your support for Kerala is the first state in the southern region which is completely integrated with PMJY from the day one of the implementation of this scheme, and that is really great. And sir has been at the helms of the affair since the day one of the launch of this scheme. So, sir, we acknowledge your support for that. Going forward about the presentation, two important takeaways from sir's presentation. First one, that state developed as Kerala, where health seeking behavior is really imbibed in the people. Even if that state is feeling the need of beneficiary empowerment, then I think all other states definitely required to take lots of effort in seeing that the beneficiaries are empowered. Beneficiary empowerment is just not limited to awareness. It is also about how to sensitize them about their entitlement, educating them about their rights, and sort of empowering them against any kind of anti-fraud and abuse which probably they would be subjected to in the hospital. They are ultimately the gullible set of people. They are not the best of they are not really the most empowered one. So that is one takeaway. Another, the integration with the different departments. What sir has line departments, convergence with the line departments like Kutum Sri, then also other labor department. That is also very crucial for seeing that our stakeholders are really aware about this scheme. Like if I talk about Bihar has lots of SHG people. They are the part of this scheme, but yet they are not able to get the benefit of this scheme. So if we can really integrate this set of people, then this is really going to fetch lots of this is really going to create lots of awareness and empower the beneficiaries. So with these words, now I would request Prasanna sir, Secretary Health Chhattisgarh. Sir's topic is convergence of this scheme and also how Ayushman card drive is being implemented in the state. So 2 lines of introduction. I would like to say one thing what Ratan Kelkar sir was talking about, the vertical convergence between NHM and NHA that Kerala has shown us, Chhattisgarh has shown us a way forward about that, sir. Chhattisgarh is implementing RBSK scheme on NHA's IT platform. So while we are doing something, but the state has also done, this is one thing about which sir will talk. And about Ayushman card drive, last year Chhattisgarh single-handedly provided us almost 1.5 crore Ayushman cards with the highest of 8 to 9 lakhs card in a single day. So that is again a sort of benchmark for all of the states to really follow and see that, we will be more than happy to have 30 lakhs card in a day. Yesterday, Minister sir was talking about 10 lakhs card. And with this, sir, I would request you to kindly make the presentation. Thank you, sir.
Thank you, Rohit. Good morning to you all. As you see, there will be 2 presentations. One is the convergence of the scheme and second is the Ayushman card. So when RSBY scheme was formed, even before that, state had its own different schemes covering different sets of people and providing different sets of treatment. And when RSBY and Ayushman was later introduced, we found out that there are many overlapping of benefits and other reasons which I will be covering in the next slide. So these were some of the schemes that were existing in Chhattisgarh before Ayushman and RSBY came. And they were providing different sets of benefits to different sets of people. So when we are implementing these different sets of people, it was actually existing under Directorate of Health Services. There were 2 parts. One was the SNA part and the other was the Director of Health Services part. And both were headed by the same person, but implementing different sets of schemes. So we found out that there is duplication of work, there is duplication of efforts. Then the beneficiaries sometimes can benefit from the different schemes. The packages, the same treatment had different package amount in different schemes. Then we have to rely on multiple IT platforms also, and some schemes under the same roof we are implementing in the paper mode, and in the parallel section we were implementing in the IT mode. And there were administrative challenges also, because some places we had staff, some places we didn't have staffs. And monitoring was difficult where we were implementing in the paper mode. And then interdepartmental coordination was also an issue. So we decided to find out which are the schemes that are existing. So we found out that there are 2 sets of schemes. One are those schemes which were implemented by the health department, and there were other schemes which were implemented by the other department, like say labor department or general administrative department, etc. So we made a presentation before our minister and the chief minister about the pros and cons of merging all the schemes. So initially they gave us the go-ahead for implementing for those schemes which are under the health department. That's why then we started implementing these schemes. So to kick off the project, we took our ration card as the single base, because Chhattisgarh historically has been very successful in implementation of the PDS scheme, and we had a very good database of it, and more than 90% of the ration cards were Aadhaar seeded also. So we used that as a base, and we built our entire platform, the health beneficiary list from this ration card list. Then when the PMJY was created, and we used the same platform for integration of the different schemes also. By this we were able to simplify our processes and also improve our efficiency. And the health benefit packages and the hospital empanelment also become very easy for us, because once they were empaneled in this scheme, then all the other schemes are also onboarded to it. And also, while designing the scheme, we had certain state-specific programs also, which is not part of the NHA packages. For example, normal delivery, so that we restricted certain of these packages to the government institutions, so that we are able to cater much better and also plow back the resources back to improving the government facilities. And also financially, if we see, since we were able to merge all the schemes, there was savings in money across the different schemes. And also single payment window ensured that all the participating hospitals also were able to get the money in a very time-bound manner. And also we created a centralized incentive schemes, whereby both the HR people who are providing the services, they were also benefiting from the operations or the packages that they were doing. And also we have created a new Chief Minister's Public Hospital Transformation Fund, where the fund generated at the hospitals are plowed back at the state level, and depending upon the needs at the different public sector facilities, then the funds were used for the development of infrastructure and other facilities in those hospitals. The good part of it is that today some of our facilities, even in the remote areas like Bastar, which is always in the news for wrong reasons, some of the hospitals there in district hospitals or the CHCs, they can compete with some of the finest hospitals in the private sector, not only in the Raipur but also in the Tier 2 and even the metros. That is the quality of infrastructures that has been created, and we are happy to see that one of the district hospital with a 100-bed capacity has an OPD of almost 900 to 1000, because of the quality of infrastructure and also the quality of HR that has been created using this Chief Minister's Fund and also the DMF and the CSR. So the future planning is that not only the schemes that have been implemented by the health department, but we also plan to merge the other government department schemes of other departments also, as the political climate gives us permission to go ahead. And also, like for example, in different schemes, say for example for normal delivery also, if you see, under NHM we have JSK and JSY and JSSK also. So if you look at the different stakeholders in this, for example, simple normal delivery, the patients, beneficiaries, they get it from the JSY and JSSK. And through our incentive schemes, the doctors, the staff nurses and the other paramedical staffs who are working, they also get from the benefits on the incentive that we have designed. And third, the hospital gets back the amount through the Chief Minister's Development Fund, by which that fund can be used for the upgradation of the infrastructure and other requirements of the hospitals. So by this, the different we try to address and benefit all the different stakeholders, so that overall the health benefit improves. So the challenges that we have faced were initially of the IT infrastructure. Long back when RSBY Ayushman portal came up, there were lots of issues we had to fight out with TCS also, and also integration. But as Kelkar sir also said that regarding integration between NHM and SNA, still there are lots of challenges to be done, though we are able to integrate little bit with our RBSK like Rohit said, but we are not able to do it in a seamless interoperability way. Actually, we capture the data in an Excel sheet, then we try to do it at the back end by integrating it. Whereas it should be, like yesterday we were talking lots about interoperability. So within the health department portals, that first we'll have to find a way of interoperability so that seamless integration can happen. And there are certain issues that I don't want to highlight right now, but we are taking it up at the Government of India at a separate level. Regarding Ayushman card creation, one of the good things is that of Ayushman card creation is that, especially at the present stage, it has a political issue also, because the present government, even in their party manifesto, providing 100% of the Chhattisgarh beneficiaries with the Ayushman card was one of their stated goal. So since we had political blessings for it, it was much more easier for us to implement this scheme. And as Rohit said, we were able to create more than 1.25 crore Ayushman cards during that ADA drive. How we did it, I'll just say, as I said earlier also, we used the ration card data, which was already available with us, and everyone in the field level also knew about the ration card, because the awareness about the ration card is very high in Chhattisgarh, and also the people benefit out of this ration card system. So it was much more easier for us to use this database. Second, one of the bigger reasons for our achievement was the involvement of the village level entrepreneurs, VLEs. When this project we took up, hardly there were 1,000 VLEs that were functional. So the department, we were able to activate this VLEs, and almost 17,000 VLEs become active. One of the reasons for is that we were having constant meetings with them, trying to address their issues. We had an online system of training them, grievance redressal, and even doubt clearing sessions were happening with them. Next, what we found out was that since in Chhattisgarh it's a rural economy, most of the people go out for their work in the morning hours and they come in the evening hours. But if you go out during the office time, that is 10 to 5, so no one will be available at their home, and they'll not be interested in doing the enumeration. So generally we planned our camps in such a way that our camps are located in the areas where they are going for work, so like Narega activities or something, early morning, or even before they leave from their home, or we had their camps in the evenings once they come back from the work. So because of this, more people were able to participate in the enrollment drive. Next was the door-to-door visits that our ASHA workers, VLEs and other peoples participated. Then we also established hardware at the hospitals also, at the various hospitals like primary health centers and CHCs, so that whenever the people come there, or also through our RBSK team also, we brought the people to these places also, where especially where we had internet connection issues or geographical issues. So we brought people also to these places so that we were able to make more cards. And we had provided the beneficiary list to the ASHA workers and the Anganwadi workers also. And also we displayed all the list of the beneficiaries in front of the VLEs and also Gram Panchayats. So the people also know that their name is there in the beneficiaries list, so there was no overcrowding issue also. And we had intimated them to come in a phased manner so that there is unnecessarily waiting time is also avoided, and wherever crowd is there, other problems also creep up. So when we said that all these people are there in the beneficiary list and you can come in your designated time for your enrollment, it prevented the unnecessary chaos that is otherwise happening. And vigorous IEC was done, like wall writing, miking, then Munadi, etc. also. And we used the EHCPs as a point of ADA drive. And if you see the motivation of the people, so Chhattisgarh has certain places which is geographically very tough because of the natural reasons, where we don't have roads, we have to cross several rivers also to cross. Even if some incidents happened, sometimes we have to even go to Telangana to come to certain villages in our own state. So these are the tough terrains. Still our people were motivated to go and prepare this card in these areas. And we have the Naxalite problems also. So these are the areas where we have to navigate those issues also, and our field team has done an excellent job in doing these things. Thank you very much.
Thank you, sir. Chhattisgarh has been the state which has really truly implemented universal health coverage in the true sense that the concept of leaving no one behind has really been followed by Chhattisgarh. Many other states are implementing USC, though. Also the sir has highlighted the fact that JSK and JSY, he is looking forward to integrate these schemes with NHA, PMJY ecosystem. So that is definitely going to help in doing away with the lots of duplication of the beneficiaries, which is ultimately making the whole scheme unsustainable. So that is one way. If we really look towards making the scheme financially viable, ultimately we will have to go for the convergence of schemes being implemented across different departments. Like BOCW is financing for BOCW workers are being financed by state welfare boards, and if states can really onboard them, then 100% funding for them would be provided by the state welfare board. Similarly, sir has. So one thing is that I understand that yesterday this topic was again discussed, that whether we should really burden the public hospitals with the requirement of doing everything on the IT system, because they are already burdened with so many things. I understand IT is not the panacea, but still it is a tool which enables effective management, because it helps us to measure things. It helps us to understand that whether these hospitals are performing or not. Tamil Nadu CEO yesterday said that they are measuring the performance of public hospital by the fact that how many beneficiaries, how many money they are earning through this scheme. So this is again a very, very effective though a top-down approach, but a very effective way of really seeing that this scheme uptake is being taken care in the public hospital. So now I would request Bhupinder sir, he is Secretary Health, Jammu and Kashmir. Jammu and Kashmir has last year launched on 26th December 2020, it has launched universal health coverage with the name Ayushman Bharat Sehat scheme. So in terms of UTs, the first UT to really have again true universal health coverage is Jammu and Kashmir, and since then the state is of course like it's not really easy to implement a universal health coverage. State is doing really great, and one best thing about the state is that even SECC, in the category of SECC beneficiaries, they have been able to identify 84% beneficiaries. So that's really very, very impressive. And today we have invited Jammu and Kashmir to talk about that two things. The first one is that how they are doing this Ayushman card drive, because that is currently at the core of everything we are doing with respect to PMJY. Second thing is how they are able to effectively address the grievances in the while they are implementing the universal health coverage. So these are two topics, sir. Thank you, sir.
Thank you, Rohit. Esteemed panelists, ladies and gentlemen, good afternoon. I'm thankful to NHA for providing this opportunity to J&K to present what we are doing and also to learn from what others are doing. So the theme area that has been given to us is beneficiary identification and feedback mechanism. Before I dwell on these identified thematic areas, I'll just set the context of how scheme has so far done in J&K. Before PMJ, J&K had no history of publicly funded assurance or insurance scheme. We launched PMJ in the year 2018 in the month of December, roughly 3 or 4 months later than the launch of PMJ. And at that time, we had roughly 25% of our population which was covered under the scheme based on the SECC data. However, post launch of that scheme, 2 years later, the government extended the same kind of benefits to the remaining 75% of the population, and I would say that there is no any other criteria to identify a beneficiary. Everybody who's a resident of J&K is covered, is provided the same kind of packages as they exist in PMJ. Secondly, the scheme is being implemented under insurance model, and I think we are perhaps one of the few states or UTs implementing it, and we have our own learnings in the process. We have an institutional setup of SHA right at the UT level and also in the districts. We have a total of 209 empaneled hospitals, out of which 118 are public hospitals and 91 are private hospitals. We had a population around 97 lakhs, which is supposed to be provided the benefit under the scheme, and out of that we have provided card to nearly 80% of the population, that is around 76.52 lakh beneficiaries. In terms of families with at least one beneficiary verified, we have nearly 91% families with at least one card as we speak. Another scheme, so far we have provided treatment in more than 6 lakh cases. In the current insurance policy, which started in the month of March this year, we have already pre-authorized nearly 2 lakh cases, and claims have been paid in around 1.5 lakh cases. As I mentioned, we are running it in the universal mode and also in the insurance mode, and everybody who's a resident of J&K is covered under the scheme. As I mentioned, we never had a history, because other states had a long history of RSBY or other similarly state-funded schemes. So in the very beginning, we had realized that the scheme's uptake will largely depend on how well we educate our beneficiaries. And it was with that logic we got the right kind of support or the initiative from right from our Lieutenant Governor Sahab or the Chief Secretary at that time. And we, in the beginning, focused primarily on the beneficiary registration. And at that time, it was a daunting task, because we also have a lot of challenges in terms of terrain, in terms of internet connectivity, and also in terms of the network of common service centers. But despite all those challenges, we could launch that drive and follow it later. And as a consequence of that scheme, that drive, we are on a daily basis clocking nearly 1,100 cases a day for treatment, which is quite significant. Our per day outgo is around 1.8 or 1.85 CR, and compounding that with the good health-seeking behavior that exists in our state, I think the uptake has been exponentially. It has only exponentially grown. I mean, in the beginning when we started this scheme, it took us 7 days to have the first patient registered for treatment, and now we are clicking around 1,100 cases a day. That's quite a journey that we have covered so far. So coming to the thematic areas, beneficiary identification, like what is our problem statement? We want to provide every beneficiary who's covered under the scheme to have a card so that he feels empowered and he knows and he feels assured that I can avail the treatment as and when required. We also have hard to reach areas. There are areas which remain unconnected during winters. And then also in the urban areas, a lot of reluctance, there are pockets which are congested, pockets which are slums where population is not very forthcoming. And then we also have a significant population which is migrant in nature. They move with their the cattle and the sheep during the year. What we did, as I told earlier, that we were very, very proactive in the sense to reach out to the community, and we had lot of camps organized, and then we launched a village-wise outreach program by the name Gaon Gaon Ayushman, wherein we had a detailed program to go to every village and help facilitate the BIS verification. There were certain families which were initially left out from the SECC data, so we did a survey using our field functionaries, that is Ashas and Anganwadi workers, on the analogy of Har Ghar Dastak that we had during the COVID vaccination campaign. We also had a similar campaign to reach out to such families which remained without a beneficiary verification. Similarly, we also tried to involve as many stakeholders as we could, be it from our government departments, but also from the community at large. We had certain focus interventions wherein we tried to involve the traders, the vendors, sanitation workers, self-help groups, Shikara Association, hotel associations. And the outcome of that is that we have nearly 91% of our beneficiary families at least with one card, and we have, I think the data has improved. We have 5 districts which have saturated the target of providing a card to each family. So in terms of individual, we are at 80%. So these are some of the snapshots of the campaign that we took to register the beneficiaries. The second thematic area that has been given to us is beneficiary feedback mechanism, and I think a lot of states have shared their own experiences, and I think we have learned from them, and this is what we have done at our end. The larger chunk of patient care in J&K comes from public hospitals. Nearly 65% of the average, the cases that are registered for treatment are registered in public hospitals, and the remaining 35% are registered in private hospitals. So J&K in that sense has a strong or a much better public health network. But despite that, we have to converge our capacities with the capacities that exist in the private market. And when we do that, we also have to ensure that a sense of scheme is preserved at every level. So we have two interventions that we initiated a couple of months ago. The first one was getting the beneficiary feedback from the hospitals where they receive treatment using QR codes. So we had these QR codes which were specifically pasted at number of locations in the hospitals, and the patients could register their feedback on the satisfaction level, on the behavior of the staff in the hospitals, and also on the aspect of out-of-pocket expenditure. And then we have a call center by 104 call center, and we have been trying to reach out to every patient who receives treatment under the scheme and take their feedback. So we have done a small analysis also. The trends are just setting in, as I mentioned, that we have only initiated it a couple of months ago. So we are trying to analyze the data as it comes, but it certainly is encouraging that the out-of-pocket expenditure that we were expecting that it would be quite high, it is not as such in J&K as of now, as maybe because we are largely getting our treatments from the public health institutions only. But this data will certainly give us a lot of insight and help us devise strategies to take care of the aspects which have not been taken care so far. Similarly, I'm thankful that I attended this conference. I could get an insight on what Karnataka has done on the patient referral system, and I think we had also done something not similar, but we are trying to analyze how many patients who report to our public health institutions first end up getting treatment in private hospitals. So the second pie chart that you have at the bottom, it actually gives us a lot of idea. So you can see that around 52% of the patients who are taking treatment in private hospitals had initially reported in our public hospitals only. So that's a lot of drain from our public hospitals to the private hospitals, and certainly we'll have to put up some strategy to take care of the aspects of patient care in our public hospitals so that we can retain our patients there, which would certainly bring more strength to our public hospitals. The outcome of the feedback mechanism, certainly the patients, the beneficiaries, they feel more empowered, and it would certainly put a check in reducing the out-of-pocket expenditure in both public and private hospitals. The quality aspect of patient care would also be addressed to some extent. We'll get a constant feedback, and that feedback can certainly be used to improve on our practices in the hospitals. The patient would also, we are getting feedback from the patients which would also give us an insight into if some fraudulent activities are taking place during the process. And certainly the staff behavior is also expected to improve based on the patient feedback that we receive. So with these thoughts, I'll conclude. Thank you.
Thank you, Bhupinder sir. Sir was the CEO SHA when Ayushman Bharat was launched in Jammu and Kashmir, and is very instrumental in strengthening the implementation of this scheme in the state. So about the takeaway from the presentation, UT from the day one, the UT of Kashmir has from the day one has really focused on Ayushman card creation within 6 months of the scheme implementation. Besides the challenges of SECC, the UT has achieved almost 60% families with at least one Ayushman card, and currently it has 84% family even with SECC data. So that's really great. And what another feedback, another sort of takeaway is that we should always be open for feedback and constructive suggestions. Like we should provide more and more avenues to the beneficiaries to provide us the feedback, to raise their grievances, and we should be open to learn and from other states and also from the beneficiaries that what challenges they are facing. Because we are constrained with the time, now I will just request Dr. Amit Paliwal sir he has an experience of almost 20 years in IEC related activities. So we have one question for him, that what is the most scientific, like all the states are approaching this awareness activity from different angles. They are doing something on their own, but if we talk about a scientific approach to do the awareness activity, like if something, because PMJY is not for everyone, unlike Swachh Bharat, PMJY is a targeted scheme. So what do you really feel that if you want to suggest the states 2 or 3 things which this would do on awareness, and not limited to educating them about their entitlement, but also about empowering them about their, any anti-fraud initiatives, like if you want to take that, how they can save themselves from this out-of-pocket expenditure which they are coerced sort of. So these are few things we would like you to talk about.
Thank you, Rohit, and thank you all the panelists. I think it was really an awesome information which came our way. And to be very honest, Rohit, that's a lot of questions bundled up into one, but maybe I'll just split my answer into 2 parts, if that's fine with you. When we're talking about information translation to the beneficiary, we basically are trying to empower the beneficiary. We all know information, knowledge is power. So we have to somehow transfer that knowledge to the beneficiary so that the beneficiary can use the whatever benefit we want to give that beneficiary. To complicate matters further, PMJ, whether we like it or not, is a pretty complicated scheme. The beneficiary needs to know the entitlement, they need to know which hospital to go to, what all benefits they can get there, how can they raise a grievance if they have to. And it's a complex scheme of things, or a complex, a lot of complicated information which needs to be translated. Now, what I think a lot of states have been doing, unlike Kerala has done, of course, a lot on social behavior change communication, but a lot of states, when I see them, they are still basically using mass media for awareness generation. By mass media, I mean print, electronic, radio, these kind of medias for raising the awareness amongst the beneficiary. And that serves the purpose of awareness. So the people know the name of the scheme, but what next? And for that, I think what we need to go back, and that is the second part of my answer, is that we should not forget that, we've had a public health system in India for 70 years, more than that. We've had National Health Mission in India for 16 years, a little more than that. And we have systems in place for communication. We have the IEC systems, we have the ASHA training centers, the A&M training centers, where ASHAs and A&Ms are trained on how to use flip books and other methods to transfer a lot of knowledge which regarding maybe maternal child health services or other vertical programs to the beneficiary. We should, I think, piggyback those mechanisms and also use the district level functionary, especially the chief medical officer. So we need to align the chief medical officer to maybe monitor our scheme. I don't like to use the word monitor, but maybe monitor or facilitate the implementation of our scheme, both PMJ and ABDM at the district level. It's very important that we somehow bring them on board. We maybe provide them with some instruments like certain monitoring indicators. Now these CMOs are anyways monitoring 20 national vertical programs under NHM. They can easily monitor 2 more. I mean, it's not difficult for them. It's just that we need to bring them into the fold. We maybe have to give them a bunch of indicators which they can monitor. Maybe we can create some dashboards at the state headquarter level which can be monitored, and we can monitor the performance. So these for me, I think, are the 2 basic things. We need to really go down. When you're talking about a scientific approach, there's a very well researched approach called social behavior change communication, which has been mastered by UNICEF, which is supporting Kerala. It's a very scientific approach to communication. It takes away all the creativity that we try to bring into communication. Very often we always feel a very creative ad is a good ad, but very often we see that ads are misunderstood. We very often see that messages can be misunderstood. We all the time see that our politicians and our other dignitaries very often say, I have been quoted out of context. And that is when the context is misunderstood. So the communication has to be field tested, it has to be researched, and only then should we use the communication material. Just thinking that there is a good communication, it looks attractive, it may not always serve the purpose. So yeah, quickly winding up, two things, maybe a scientific approach to communication using the SBCC mode and the existing public health mechanisms, and the second would be maybe bringing in the district level functionaries, bringing them into the fold, using their the strengths of that part of our public health system to kind of further the implementation of PMJ and ABDM. Thank you.
Thank you, Paliwal sir. So like he highlighted that, if I sum up whatever he said, that we need to move from ad hoc approach to a more scientific and a robust approach towards awareness. I understand that many of the SHAs are constrained by the human resources and technical resources, but yes, like we have a hierarchy of needs, similarly we have a hierarchy of awareness. Like it starts from just simply making them aware about their scheme to the making them aware about their entitlements, then they're sort of creating a kind of some kind of empowerment where they would resist any gullibility which they would be entrusted by the hospital. So that is required to be done by the SHAs, and also NHA is partner to this process. Now, before we request the chair to sum up, or I would request co-chair for the session, Dr. Pradeep Bas sir, to kindly talk about that. Maharashtra is, like amid everything we have been talking since yesterday, when we go towards the USC, the one question which arises is the financial sustainability, the financial viability, and Maharashtra has really done a great work. Like the premium is still 797, and sir has been at the helm of affairs from the day one. So with regards to all that we talked about, in addition to what I said, I request sir to kindly sum up the session, and then we will request the chair for this.
Good afternoon, everybody. I think we have already overshot the session timing, and I had requested Rohit not to call out my name because I was last minute unintentional addition to this eminent dais. But I believe this premium issue is directly related to number of the fraud or the spurious claim. An insurance company, if they have a full faith in your system, then naturally the premium will come down. And second thing is related to something about reinsuring mechanism. So I will just like to elaborate on these two. When we floated this tender for the first time somewhere in 2020 around, or even before that, twice we failed. Then we analyzed that why it is happening that we were running the scheme at 333 rupees per family, and now we are getting a quote of in the range of say 1600 and 1700. Then we realized that there are two issues to that. One is that we need not limit the competition to government insurance company, and second, we realized that government insurance company in turn give it to some reinsurer and pass it on to them, and they get only 5 or 10% profit. So expressly in the next tender, we precluded that no reinsurer should be involved by the insurance company. And then immediately our premium came down by half. And second thing is that we feel pride that we have a system in place, though fraud and spurious claims do take place, but we are in a position to detect them. And these two probably got us the premium low. And third point, probably we excluded all those packages which PMJ has, but they are not well defined. Many times I had a conflict of opinion with the NHA authorities in the beginning, because there are so many packages which are not very well defined. One package can spill over into the next package, and some packages, particularly the medical packages, which I think somebody also mentioned in the forum. So mostly our packages, almost all of them are the surgical packages only, and there are well-defined indications as well as the documentation part. and that probably got us this thing. And coming to the summing up the session, I think Rohit has already summed up it very well. And I am here just to imbibe that what are the good practices which other states are following. So starting from Karnataka, there is this gatekeeping model and keeping some procedures reserved for the government. And that same thing many states are doing. We also do that. In our state, we reserve about 130 odd procedures specifically for the government. And it is a very dynamic and live list, because we keep detecting that suppose sometimes the hearing aid or some such operations are being misutilized, and we reserve it for the government. And but their system seems to be much pretty strong, because they have this referral slip, which we do not have. That if suppose that procedure is to be done in the private, then it is to be routed through the civil surgeon or the district authority. I think this is a system which other states probably definitely can adopt. That model which Madhya Pradesh had, that about the beneficiary facilitating agency. I think this is a system which should be tried, because in our own hospitals in Maharashtra, we feel that many government hospitals do the procedures, but they don't claim, because they are so overburdened that they have no time to fill up those forms and claim the amount, which otherwise would have contributed to their kitty, and they would have been in position to build up some infrastructure. We did lot of relaxation. We increased the claim submission time. We gave lot of relaxation, like repeat ultrasonography need not be there, because many times, like to give you an example, that in our KEM hospital, which is one of the very busy hospital in Mumbai, so if after hysterectomy, if you have to do the repeat ultrasonography, the waiting period can be as long as 4 to 6 months. So, so some of these concepts which Madhya Pradesh is implementing will be very useful. And this Chhattisgarh model of other schemes, NHA and NHM, which he mentioned, Rohit mentioned, is worth simulating. The Kerala model, always we look forward. We are basically, all the health meetings, there cannot be no discussion without Kerala and Tamil Nadu being talked about. We are maybe a close second or close third in Maharashtra. So I learned a lot about, we can all learn a lot about particularly the involvement of the public, because the public is the key, the ultimate beneficiary, ultimate person who has to get the benefit. So how they have involved through their IEC activities, the general public, many mechanisms which Kelkar talked about. And in J&K, Bhupinder talked about that in spite of all those challenges of that state, how they could do very quickly. And I am really enamored by all these states, because CEO sir is here, and his main grievance against Maharashtra is that we are not issuing any PMJ card. And here I was listening that 8 lakh cards a day, so 1.5 crores card. So maybe our structure is like that. We are ration card based scheme. People don't have any incentive to get probably, but I think it has really motivated me, sir, that I will come up with your expectation, and Maharashtra also, we will start issuing cards at a much higher speed. Thanks, sir. Now over to Suleiman.
But,
Thank you, sir.
you know, my eminent batchmate and a doctor himself, after he summarized everything, I have nothing more to add, other than just to say to R.S. Sharma sir, that for the states, 4 years is a very small, time. For us, it's still a work in progress. We still have to learn many things, and we still have to learn from each other. So these kind of discussions in which we get to know what others are doing are definitely useful. Unfortunately, because of paucity of time, we couldn't really hear from the participant about what they expect us as a state government to do so that we perform better. But maybe some other opportunity we'll get to hear more about that. Thank you very much.
Thank you, sir. Thank you very much. This was really illustrious discussion about what states have been doing and leading the implementation from the front. And now we will have a small felicitation part. And yes, over to you.
Thank you everyone for such an enlightening discussion, and it is truly amazing to see the work that is being done by the states in implementing the scheme. I would like to now invite upon stage Dr. R.S. Sharma, CEO, NHA, to come and help us for the Memento distribution ceremony. We'd first presented to Chairperson Mr. Mohammad Suleiman. Co-Chair Dr. Pradeep Vyas. Shri T.K. Anil Kumar. Dr. Ratan Kelkar. Shri Prasanna R. Shri Bhupinder Kumar. And Dr. Amit Paliwal. And Vishalakshi Ma'am, CEO, SHA, Telangana. Ma'am. We'd also like to invite CEO, SHA, Anurag Chaudhary, Madhya Pradesh. And we'd also like to call upon stage Dr. R.K. Patel, Member Governing Board, NHA. Thank you all. There's a small lunch announcement. Lunch for all our delegates is served in... Okay. We'd also like to call upon Ayushi from Jammu Kashmir, CEO SHA. Also like to call upon stage Bhim Singh Sir, CEO SHA Chhattisgarh.